So everyone, welcome to all the participants today. I'm Ellis Ming. I'm the VP-elect for Technical Activities of the IEEE Engineering in Medicine and Biology Society. I'm based at the University of Southern California in the Department of Biomedical Engineering. I'm delighted to welcome everyone to our second webinar of our inaugural Distinguished Lecturer Series. This is a new initiative of our Technical Activities portfolio and brings us a new way to enjoy our distinguished lecturers to our members, right? We'll put these seminars on regularly. So if you enjoy these, please join us for future events and be on the lookout for those announcements. All of our webinars will be recorded. So if you can watch these and rewatch these as needed, and also share them with other members who couldn't make the live event. I'm delighted to welcome Professor Zarah Moussavi from the University of Manitoba, where she is Professor of Biomedical Engineering. In fact, she founded and then served as director for the Biomedical Engineering Graduate Program. Her research interests are in medical device instrumentation and signal analysis for the management of sleep apnea and Alzheimer's diagnosis and treatment using a suite of different technologies. We will be hearing about this latter work today. Professor Moussavi has won many awards and accolades for her research and is recognized as a Manitoba Distinguished Woman and one of Canada's most powerful women. I would like to ask that if you have a question, to please look at the bottom of your Zoom screen and access the Q&A feature. Please type your questions in. You can type them during or after the webinar is given. And then I'll ask those questions from that Q&A box at the end of the talk. So now I would like to turn it over to Professor Moussavi, who will present on non-pharmaceutical treatment of dementia.
Thank you, Alice, and for the introduction, and thank you for inviting. And hello, everyone. I can see a few familiar names among the attendees. In fact, one of them has seen this presentation before. But anyway, we continue today. Let me share my screen. Is that okay now?
Yep, we can see it.
Okay. As Elise mentioned, I'm going to talk about non-pharmaceutical treatment options for dementia, in particular, Alzheimer's. First of all, Alzheimer's disease, the way I see or feel it, is very much like a thief that comes and steals away the most precious memories that people identify themselves with. In fact, it is a very clever thief because people who are lost, they don't even know what they have lost. They just feel lost in time and space. So the main question is how to slow the progression of dementia, or again, in particular, Alzheimer's. And even more important question is, can we age with a healthy brain? I'm not claiming that I'm going to answer all of these questions, especially the second one, but I can just review a few research that has worked on the Alzheimer's dementia treatment. So as you know, that there are medications. So the question is that, do they really help? And non-pharmaceutical treatment, there are a number of them, like rTMS treatment, TACS, TDCS, Transcranial electromagnetic treatment, oxygen therapy, daily cognitive exercises, and music, physical therapies, all of that. And the question is that, are they facts or fiction? But before we start into treatment modalities, perhaps we need a little bit to review what happens in the brain of a person who has dementia or Alzheimer's. And by this clock, I meant to refer to the famous test that is for Alzheimer patients in particular, because they lose their spatial orientation. And usually they are not able to draw a clock correctly. And that's one of the main tests that all clinicians, researchers run at the beginning of any study. Alzheimer's brain, we can talk about it, that the cortex starts to shrink. The damaged areas involved in thinking, decision-making, planning, and remembering. These shrinkage atrophy is particularly severe in hippocampus area, which is an organ that is not to store the memory, but is responsible to form long-term memory. Basically, if we don't have our hippocampus, we cannot convert any short-term memory to long-term memory. However, the long-term memories can remain intact. That's why that dementia patients, especially at the beginning of the disease, they do remember their long-term memories, but they don't remember the recent memories because their hippocampus is being impacted and they can't form long-term memory anymore. Furthermore, the ventricles, as you can see in this picture, they are being enlarged and grow larger. By the way, I must say that this picture, the right side, that shows an advanced stage Alzheimer's, it is by autopsy after death of a very, very advanced stage. The brain of the Alzheimer patients right at the beginning onset of the disease actually do not show much differences to a healthy brain. That's why that the imaging modalities alone cannot be used for as a diagnostic biomarkers for Alzheimer's. There are many papers that claim that they can detect biomarkers through the imaging studies. Sure enough, if a patient is advanced a few years past Alzheimer's, yes, but not at the onset, because we all have some changes in our brain as we age. We have about 80 billion neurons, and in a brain of a person who has Alzheimer's or dementia in general, there are some atrophies. They have fewer nerve cells and synapses. And basically there are plaques, abnormal clusters of beta amyloid fragments built up between the nerve cells. And more importantly, there are tangles of tau protein, which new study says that it is basically the tau protein that is the main culprit. And in the presence of the tau protein, beta amyloid behaves badly too, in a very simple term. And therefore, it leads to the synaptic dysfunction. Again, the picture shows the difference between a healthy cell as opposed to an Alzheimer's cell. For us, I think the audience are all engineers. For us, the engineers, perhaps we understand it much better that when the cells are healthy, the communication channels between the cells that are called synapses, they are like healthy, normal communication channels. And in the Alzheimer's brain or dementia brain, these communication channels are being disrupted. And therefore, the signals between the neurons cannot be transferred quite easily as before. And that's why that people start to become confused or not remembering what to do, and other symptoms that they show. So as I said, basically it is the tau protein accumulation plus the beta amyloid plaques that cause a profound synapse degeneration. And these abnormalities in terms of beta amyloid plaques or tau protein tangles disrupt, in particular, frontoparietal function connectivity. And medications that are usually cholinesterase inhibitors usually try to suppress tau, although not so effectively. So the question is, how about the non-pharmaceutical treatment like TMS, TACS, EMBS stimulation, and so on? What do they do to the brain? So in terms of medication, these four that I have listed are the most common one. In fact, among these four, again, Aricept or donepezil, which is its generic name, is the most common. And perhaps it would be interesting to know that despite the fact that almost every single patient is having Aricept or one of these four common cholinesterase inhibitors, the response rate to medication is pretty low. In fact, the drastic response to Aricept, drastic in terms of so that the family members are noticing a change in the patient's symptoms too, is only 1 in 42, pretty low, 2.5% response rate. However, I must say that the mild or moderate response or stabilizing effect is about 30 to 40%. And how about non-pharmaceutical treatment? Well, none of these treatments have been large enough compared to the medication in order to compare really what is the response rate. So the majority of, that's the main limitation of non-pharmaceutical treatment, that the sample size. The majority of them are in a small sample size. I'll go through the sample size a little bit as I explain all of them. By the way, Alice, would you mind to tell me 5 minutes in advance to the end of the talk that I have? Because I may get carried away and talk too much.
Sure, no problem.
Thank you. So I will talk about these. You probably might have noticed that I've omitted oxygen therapy because I haven't read their paper yet. That's why. So I talk about the techniques that I have read the paper or I do it in my labs. Starting with visual stimulation. This lady at MIT a few years ago started a study on mice, only at mice, and gave the flashing light to the eyes of the mice at 40 hertz and saw that the tau protein was suppressed on those. Apparently, her research inspired a group who have established this light therapy. They call it V-Light Neurotranscranial. You can search on Google to see more about this company. They are selling their technique even to home, to people. And what it does is that it puts some electrodes over the scalp and emit near infrared lights. And they use 810 nanometer with a total power which is less than 100 millivolt. You may question whether the light can penetrate the brain or not. Well, there is a study that shows, yes, near infrared lights can penetrate the scalp. And in fact, there is an imaging modality based on that too. It is called FNIRS, functional near infrared functional imaging. Don't mistake it with fMRI though. FNIRS is different. Anyway, there is a study that shows that about 1,000 nanometer is best to penetrate the scalp. Whether it is being absorbed or not, it is beyond my knowledge in neurophysiology, but they claim that it is absorbed by cytochrome oxidase in mitochondria of the cell. And the pilot study that this company published was started with 19 patients, supposed to be a crossover design between sham and active, placebo and active. But all the sham people dropped from the study, and the study ended up with only 5 people who kind of finished the study with real active light therapy. And 5 is too few to draw any conclusion. You can find their paper online and read it. They are running a clinical trial right now. It started a few years ago. It hasn't been finished. They had contacted me as well to be one of their collaborator. However, our deal broke up in the middle because I wanted to have the right for independent publication too, which was not allowed. Anyway, I haven't seen any other publication on the result yet. They have done some on 20 healthy people as well, and compared the EEG data right before and after 10 minutes light therapy. There is another one called transcranial electromagnetic stimulation. This group had 8 patients, 2 months, every day for 1 hour a day. This is also a very non-invasive and harmless technique. Like a light therapy, people don't feel anything. But in this study, they use antenna. It is, in a very simple terms, you may consider this technology similar to have, let's say, 8 iPhones or cell phones attached to your head. And because it uses radio frequency signal. But it was quite a good study. This is what I have quoted here. It was published in June 2019. They had imaging, and they also measured the CSF, which is a difficult measure. That's why that I'm saying it was a very good study in terms of assessments, but of course only had 8 patients. What they showed was very mild cognitive improvement, not to the extent that family members noticed anything, but they showed that the imaging in particular and CSF measure showed that it was helping with the TACS suppression. That's why that I'm saying that it is a good study, because the CSF measurement is one of the very good assessment that is not easy to get in large population for sure. It worth to continue to see what it would be its effect on larger population. Now I'm going to focus on rTMS, cognitive exercise and cognitive exercise plus TACS, and also talk a little bit about TDCS. rTMS is short for repetitive transcranial magnetic stimulation. That is my lab, and the picture shows myself and one of our very good patients in our current clinical trial. It is basically a very simple technique. It has been around for the last 50 years. It was developed in UK initially, and it creates electromagnetic field, and these pulses induce a current inside the brain. There are different coils associated with this device. This device, as I said, is a very simple device in a way. From engineering perspective, it is huge capacitors that develop that electromagnetic field. As I said, there are different coils. The most common coil for that is figure 8 coil, that this shows the winding of the coil, and our simulation also shows that the center of the intensity of the pulse is with this winding is at the center of the figure 8. And we hold this coil over the scalp of the brain. Basically, we actually touch the scalp. And rTMS uses the magnetic field, as I said, to induce electrical field within the brain. Therefore, it causes ion movements, and that means nerve cell activation. So it basically excites or inhibits the neuron directly. Depolarizes if it excites, and hyperpolarize if it is inhibiting a neuron. It is known that the low frequency pulses, low frequency at usually at 1 Hertz, but less than 5 Hertz, has been shown that it reduces excitability. Basically, it is inhibitory, and high frequency pulses more than 10 Hertz enhances the excitability. basically, again, it excites every neuron. In order to be excited, it needs a stimulation above 30 millivolt in order to develop an action potential, which is about 100 millivolt. So TMS pulses, if it is given at 100% of resting motor threshold, it excites, it is capable of exciting the neuron, making it activated. So there are some parameters in rTMS to be considered. One is the frequency of pulses, because as I said, you can give it either excitatory or inhibitory. For treatment of dementia, we always give excitatory. TMS has been used for treatment of depression, nowadays clinically approved. And treatment of depression has different protocols. Some give excitatory to the left side of the brain, but inhibitory to the right side of the brain. That's the most common protocol. Some give only inhibitory, some give only excitatory. There are many different protocols. But for dementia and Alzheimer's, we always give, not only my group, but every group in the world have always given excitatory protocol pulses, usually at 10 hertz or 20 hertz. There are studies that have tried higher frequency at 50 hertz, but in theta burst protocol as well. The other parameter that is important is the number of pulses and the train of the pulses. How many duration? The rTMS pulses, it is not just one continuous train. You have to allow some time between the train for the neurons to absorb this field and be able to respond. Because if you keep stimulating, the neuron may not even respond anymore to the pulses. So there is an entering train interval about a minimum of 10 seconds to 28 seconds between the trains. And each train usually is about 1.5 seconds or 2 seconds. So depending on what is the frequency, we give, let's say, about 100 or 150 or 200 pulses within each train. So it starts like a woodpecker, give a poke to the brain, stops, about 10 seconds, then again another poke, train of the pulses to the brain. The total number of the pulses is important. I have, in my team, I have given 1,500 pulses in my current clinical trial, but I've also tried 4,000 pulses to the brain as well. And I haven't seen much difference between the two protocols, basically. It seems to me that is not a very crucial number. Above a threshold, then perhaps increasing it from 1,500 to 4,000 per day is not going to make a huge difference. Another parameter that is important is the treatment dose. What do I mean by that? How long is the duration? The treatment is usually every day. It can be either 2 weeks, 3 weeks, 4 weeks, 6 to 12 weeks. In my team, I have tried 2 weeks, 3 weeks, 4 weeks, but an Israeli group have tried 6 and 12 weeks consecutively. Another important area parameter is the target area. We can apply most of the investigators around the globe who do apply rTMS to the brain, they have applied a dorsolateral prefrontal cortex, which is these two parts of the brain. Why? Well, because either side of this dorsolateral prefrontal cortex can likely activate the basal forebrain cholinergic complex. And since the prefrontal cortex is the hub station of the brain and has projection to almost every other parts of the brain, the hope is that via GABAergic inputs, it can reach even deeper parts of the brain. So It can also increase cerebral blood flow, glucose metabolism in stimulated and also remote areas of the brain regions, or at least this is the hope and the hypothesis. And therefore it enhances brain synaptic plasticity. That's what we are hoping. We are hoping that we stimulate the neuron, and by doing so, since the neuron is activated, the synapses are being activated, and repeated activation of these synapses can strengthen the synaptic connection, as well as maybe regenerating some synaptic connection. And that is called synaptic plasticity. I was one of the very first person who in Canada and US basically ran the very first pilot study of rTMS. Like many others, my pilot study was also very small, only 10 people. And even that 10 people were not only at the earliest stage, but it was various. Some of them were earliest stage, some were moderate stage, but they were all early to moderate stage. The study design was crossover, which means that half of them received sham treatment, the other half received active, but then due to very small sample size, I used crossover, which means that after the period of the study, immediately we did swap them. The sham group then received real treatment and the real received sham. It was also double blind, means that the patients did not know if they were receiving sham or real, and the assessor also didn't know who received sham, who received real. And there is a sham coil, by the way, that produces similar effect as the real coil, so that the patients wouldn't know, they cannot detect whether it is real or sham. And in this design, all of the patients received both active and sham treatment. We used MOCA, like MMSE. MOCA is a standard questionnaire, a short questionnaire, to assess the changes. And this plot shows the difference between sham and real. Our study protocol was 4 weeks. The first 2 weeks was every day. Week 3 was 3 times a week. Week 4 was only 1. And it shows that on week 2 and 3, the result was significantly different between the sham and real. In fact, the real showed improvement. However, as you see, it seems that on the 4th week, they were declining again. I mean, they were losing their improved state already. Again, due to very small sample size, it was just a pilot study. I'm not reading too much from it. Nevertheless, it provided the means for me to apply for a large grant to run a large clinical trial, which is, at the time that we were funded, it was the largest in the world, but I haven't finished the study, but I have seen the result of another large study, I mean 121 patients in the study with rTMS as well, more or less similar protocol. Otherwise, all the other studies have been with 45 or 30 or 15 and so on. My current rTMS treatment is multi-center, international, between Canada and Australia, and also between Manitoba, where I am, as well as McGill in Montreal and Monash University in Melbourne. It is randomized, double-blind, placebo-controlled. Half of the patients randomly are being assigned to sham and the other into real. Actually, not half. We have a randomization protocol too. It is either 2 weeks or 4 weeks, sham or active treatment. Assessments, many, but mainly ADAS-Cobb, which is the most common standard questionnaire to assess Alzheimer's. We also assess the caregiver to have their subjective assessment. We also assess their spatial temporal cognition and so on. We assess before and after, as well as every 2 months after the end of trial, up to 6 months, because we are interested if among those patients who are responsive to the treatment, how long this the effective response is going to last. All patients in the sham group are being offered the active treatment after the period of the study. I cannot talk about the results because I'm not supposed to. The study has not been finished. And unfortunately, due to pandemic, it has been a year that the study is on hold. And no matter how much I tell the health authorities that, look, as much as safety for COVID is important, these populations are also important because they are losing. And just to tell you the truth, how much the pandemic has affected this population that we are targeting. One of our patients who was actually responsive to the treatment committed suicide and passed away. 3 of our other patients who were in the treatment, 2 of them hadn't started treatment, they were enrolled, but then because of pandemic hadn't started. They declined so fast due to isolation, perhaps during pandemic, that they have been ended up in nursing home, and therefore they can't receive the treatment either. We only enroll early and moderate stage, and the decline rate during pandemic has been much, much faster, as I said, perhaps due to isolation. That's quite unfortunate. The other, talking about other types of treatment now, one is TDCS. It stands for Transcranial Direct Current Stimulation. And it just gives a DC signal to the brain, very much like TENS that physiotherapists give to the muscles. But this electrical current, a very small current, about 1 milliamp, 1.5 milliamp, is given through 2 electrodes over the skull. There is another one called TACS, Transcranial Alternating Current Stimulation. There is a typo there. Since I'm an electrical engineer by training, I chose TACS as default. Why? For a very simple reason. Before even I study the mechanism of their effect on the brain, my intuition was that I go with the AC signal, just because the AC penetration to the brain is more than TC. That is obvious because we know that the skin and tissues and the scalp resistance to the DC signal is much, much higher than AC. AC can penetrate better than DC. Application area of this TDCS, TACS, again, usually is dorsolateral prefrontal cortex. Remember that I said our prefrontal cortex, which is right behind the forehead, is the hub station of the brain. It helps if you go after the boss and treat that area and hope for synaptic plasticity in the other parts of the brain. And frequency of application, well, it can be DC, of course. People have applied at different brain waves, like alpha band, beta band, or gamma band. 10 hertz is one of common frequency. I did at 40 hertz because 40 hertz is gamma band, and it is the frequency range that our brain produces when we pay attention to something and when we are learning. Right now that you are listening to my talk, if you are paying attention, your neurons in the brain, in fact, is emitting 40 hertz brainwave. it is, we give the sinusoidal, but of course the brainwave is never sinusoidal. It is more random noise, but it has an envelope of the 40 hertz. For that reason, some people use random noise. I haven't tried random noise, but I'm curious. I would like to try that too. And the type of application, it could be cathodal or anodal. We use anodal for the brain, positive on the left side, negative on the right side. There are two hypotheses for the mechanism of TACS. One is that TACS directly entrains brain oscillation, and it aligns such intrinsic activity to the phase of external driving force that we are giving to the 40 hertz. Keep in mind that TDCS, TACS, which gives an electrical current to the brain, it is just in the range of 1.5 milliamp. It is by no means enough to excite a neuron. It doesn't. It is just increasing the excitability of the neuron. It doesn't excite the neuron on its own. And keep that in mind, because I need to refer to that when I talk about brain exercises. TMS excites the neuron directly, but TACS, TDCS just increase, it boosts the excitability. The second mechanism is that it leads to synaptic changes via spike timing dependent plasticity mechanism. So these two are hypotheses that why TACS may help to increase the excitability of the neuron. Now, let me talk about a little bit cognitive exercises, then I get back to those two TDCS, TACS, because they are usually used in combination with brain exercises. Okay, the common phrase, use it or lose it, usually is applied to the muscle, obviously. As we age, the audience are probably young people, you don't think about aging, but as we age, if you get to my age, if you don't exercise, yes, you lose the muscles. Even for yourself, for young people, if you go to gym and build up your muscles, if you don't go to gym after a while, you lose whatever you have built. You lose the diameter of your muscles too. Some people use it for brain. I do as well. But the question is it true? Is it fiction or fact? Interestingly, at the time that I started investigating about this, right at the same time, there was a paper published by Bobby, this fellow in Western University in Canada, who claimed, he was not the only one who claimed that, but the coincidence of publishing this paper right at the time that I was investigating was interesting. He claimed, along with a few others, that there is absolutely no benefit of brain exercises in general. There are other researchers who have shown that yes, there is no claim, no benefit of brain exercise to age with a healthy brain, or avoid dementia, or even to benefit people who have dementia. So, is this true or fiction? Well, we'll see. I continued. I didn't get discouraged and continued my study. This was 2018. Okay, so I had developed at that time a new series of brain exercises. Later on, developed it as an app for iPads. I call it now Mind Triggers. You can find it on App Store. It has 7 different types of exercise. Not necessarily every exercise is unique. By no means I am foolish enough to claim that these are all unique. No, just 2 of them are unique, I would say. And these different exercises, I designed them mainly based on observations from our patients with Alzheimer's, and the goal has been on increasing the connectivity between different parts of the brain, in particular between left brain and right brain. You may know that for example, we read exclusively with our left brain, or we see exclusively almost with our right brain. Pattern recognition is the job of right brain, but left brain reads the words. For example, in this picture that you're seeing, pattern recognition is the job of right brain, but connecting these geometrical shape to the animals' names is the job of left brain. And so this means we are using our associative memory to make a connection between a geometrical shape and an animal that usually there is absolutely no association. It's a fake association. I'm trying as an exercise. Why I focus on this one? Because it is known that by aging, we lose our associative memory. It declines a little bit. So the goal of these games is to strengthen associative memory. And we give these blocks of pictures, we train them to make association between a triangle, for example, with a duck, something like that. And at the end, we ask them, okay, which animal was associated with what shape? It has many different levels. For a young person, healthy adults even, this is so easy to do. But for dementia patients, it's not that easy. And the goal of my app, by the way, was not for young people. It was to design it for older adults who want to improve their memory, and as well as people with dementia. So just a couple of the games, it has enough perhaps even for a younger person, but the rest of them are basically for older adults.
Zara, I wanted to give you just a 5-minute warning.
Okay, thank you. So I should speed up. There are some other games too. Again, focuses on left brain, right brain connectivity, and that is my favorite game. Works on spatial orientation. Anyway, I investigated the effect of cognitive exercises with and without TACS. Remember I said that TACS alone doesn't excite the neuron? It doesn't. It increases the excitability. But brain exercises, any type of brain activity excites the neuron, of course. You need to excite your neuron in order to communicate, in order to recognize the shape. So I had one group only cognitive exercise and another group cognitive exercise plus TACS. And I'm presenting the results of people with dementia, and I've had quite a number, definitely more than 30. However, I'm presenting the results only on people whom I have had a full diagnostic report from their physician. So I was 100% sure what was their, basically their dementia type, whether they were Alzheimer's, vascular dementia, Lewy body dementia, or what. Exercises used was Mind Triggers app, not on their own, but with the help of a tutor. And the assessments was totally independent assessments because I was interested to investigate the FAR effect. I wasn't curious to see if the patients do better on the games, but wanted to know if they, whatever they improved, did it have any effect on similar brain activity, but not exactly the same? This is called FAR effect, basically. So the two group, I had 19 in people who received brain exercises and TACS, and 10 age-matched who received only brain exercises. I did not do randomization. That's why that you see they are not balanced in terms of size. 4 weeks every day for 2 sessions of half an hour with half an hour break in between, and with the help of a tutor, an instructor who gave them a hand on which exercise to use, or also a little bit explaining, giving them a hint whenever they need it. Assessments were at baseline, post-intervention immediately after a month, and the follow-up a month after we ended the trial. And I'm repeating this protocol every 4 months. Some patients come every 4 months. I have the result of longitudinal, but I'm not presenting it here. Okay, let me show you some protocol of TACS. 1.5 milliamp peak to peak sinusoidal, 40 hertz, and electrodes over dorsolateral prefrontal cortex, delivered simultaneously with brain exercises. Assessments were WMS, and as well as a spatial orientation test too, which was independent of that hexagonal room that they were practicing. Okay, let me show you the result of primary outcome measure, WMS. Orange is the group who did only cognitive exercise. Blue is the people who received also TACS and cognitive exercise. The results showed that they all improved from baseline to post-intervention, in fact, quite significantly. The p-value was less than 0.008, and there was no practice effect between the sessions for the primary outcome measure. More interestingly, look at the changes from baseline to post compared to the changes from baseline to follow-up. There is 1 month's time lapse between post and follow-up, and this 1 month there is no exercises, there is no treatment. People who receive TACS, it seems that they also kept improving, or they kept their improved state much better than the group that didn't receive TACS. So both groups improved, more or less the same. However, people who received TACS, they improved, they kept it better. It lasts longer. And the result was significant between these two groups at follow-up. That tells me, and also the spatial scores was also giving us the same result, that they both group improved more and less the same. Although in terms of a spatial score, I didn't see that difference between the two groups of TACS and not TACS. So in summary, more than 90% of those 29 people improved significantly after a month. 10% didn't improve, but they didn't decline either. And the application of TACS simultaneously seemed to enhance the positive effects of the cognitive exercises. So I would say it is cognitive exercise that is doing the main job. TACS boosts this a little bit better. The paper has been published. It is available online. You can search and read more if you're interested. And the main conclusion is that I would say the key for these cognitive exercise to be effective is delivery mode. Remember that I gave it with a tutor. It is similar to if you hire a personal trainer to do exercise on your muscles and your body, and or go to gym or do it at home. Obviously, if you hire a personal trainer, you improve much better. So I would say use it or lose it. It does apply to the brain. However, again, another key is to keep it a dynamic, challenging, and engaging. These are quite important. If these are not existing, then the brain exercises, of course, will not be effective. Last, I would like to acknowledge all the grant funding, as well as the participants of my study, and my late mother, who was inspiration for me to start all this research. Otherwise, I was a happy electrical engineer focused on signal processing. I knew nothing about neuroscience before my mom got Alzheimer's. And last but not the least, thanks to my team and volunteers, this picture shows only a part of the team in 2018. Okay, I would be happy if you have any question.
Well, thank you so much for the inspiring talk. We do have a number of questions that have been posted by the participants. I'll start, actually, I'm going to go a little bit out of order. So the first question comes from Ali, and Ali is asking, what is the main challenge with these Alzheimer's patients? Is it actually the early detection or is it medication?
I would say early detection, because there are studies that even say Alzheimer's disease in particular, again, starts up to 20 years before clinical symptom. Well, I don't know about 20 years, but I doubt, I would say for sure, quite a number of years in advance. And we know that when we start treatment, no matter what, if it is medication or non-pharmaceutical treatment, if we started at the onset, the results are much better. I have seen it, and this is proven for almost every disease. So early detection means even before the clinical symptom appear, before a patient can be officially diagnosed, is important to be diagnosed. In case of my own mother, I took her to neurologist twice in year 2000 and 2001 when she came to Canada. And both times I was told by the neurologist that you are imagining your mom is fine. And indeed, she aced that MOCA test both times. But I was sure that there was something wrong with mom. Mom was a very smart woman, could disguise her problems. 4 years later, she was diagnosed in Washington, D.C. With Alzheimer's. So yes, early detection is the main challenge, I would say.
And it sounds like, based on what you just said, that there are not sufficient means to do that early diagnostic well.
Yeah, that requires a separate talk. I have. Right.
Okay. So next question is, are there any studies indicating how the excitation of neurons in the DLPFC change the firing patterns of the hippocampus or other regions of the brain that are part of memory pathways?
The problem is that we don't reach hippocampus. We can directly investigate that. EEG, you know that it is a gross superposition of all brain activities. In fact, it tells us nothing because it's superposition. We can't access hippocampus to know how any of these treatment is affecting hippocampus. With functional MRI, maybe there are some hopes to find it out, but not again, you can do functional MRI just during the activities, during the treatment. That's the limitation. So we don't know. Animal studies, if you think that by putting electrodes right onto the hippocampus and do it to the animal, while we cannot duplicate this rTMS, for example, for the animals, because we don't have a coil small enough to give stimulation similar way that we give it to the brain of humans to the mice. We don't have the technology to make the coils that small. So basically, no, we don't know. So
there are some opportunities there to improve the tools, right? So these similar studies can
Definitely.
be done.
Yes, coil development is a great area for engineers to contribute.
All right. Another question, you said that 90% of MCI improved, and so the question is, how are they improved?
Well, based on, I had two one standard questionnaire, which is called WMS. It is a standard questionnaire for older adults and people with dementia. Their scores improved, but also based on the family members' subjective perception as well. This is a good question. I should mention it that when you read a scientific paper and people are presenting that, yes, the result of our treatment improved the cognitive scale by this and that, the scores in the questionnaires, even if when we find it's statistically significant, it doesn't necessarily mean that the family member have noticed something. So the best is to use a combination of family members' perception as well as the subjective feeling of the patient himself or herself, plus the standard questionnaire. These are the challenges that we have. I'm personally, since this study was very personal for me, I have always been very close to the patients. I've always been asking that, okay, tell me how it has been effective or not effective for your patient, talking to the caregivers. And to be honest with you, the best that I have seen, the best of the treatments that I have tried, it seems to me TACS plus cognitive exercise is the safest and the best, creates the best response. And besides, it can be applied to almost any type of dementia, regardless if the patient is vascular dementia or Alzheimer's or PCS or Lewy body or other types. That's my personal feeling, I would say. I can't say it scientifically yet.
I guess I do have a follow-up question to that. In your study, it seems that the exercise, the cognitive exercise is done outside of the actual treatment. Is there any benefit actually to combining both of them to be concurrent at the same time?
Definitely. The more brain exercises, the better. It's obvious in a way that if you become a couch potato and do nothing in your brain, yeah, we lose our neurons. It is the design of our body that if a cell is being inactive, the brain itself say that, why should I feed you? Go die. So if a neuron is not activated, it will die. We have to activate our neuron so that the synapses being strengthened. If we don't exercise our brain, the synaptic connectivity, it is like a path that nobody walks on it. So the grass will grow on it. Don't let the grass grow.
This is good advice, especially during the pandemic, for people to not forget to exercise all parts of the body. So I think we have time for one more question, then I'll close the webinar. Does the status of the disease affect the resting motor thresholds?
Good question. There are studies that say so. For that reason, we also investigated on the resting motor threshold different compared to level of their cognitive status in our population. So far, we have had 133 patients enrolled in our clinical trial. And we just submitted our paper to the EMBS conference. We haven't seen it. But there are some people who are claiming that the more advanced, the lower the resting threshold. But I haven't seen it in our 133 population to be strongly correlated.
So I have a plea from one of the participants to ask one more question. Sure. And so this relates to medication. And the question relates to that there's been no study that's shown that the medications have succeeded in healing Alzheimer's patients. I want to hear a comment on that.
Well, there are tons of studies, especially on Ariceps, that you can find. They are available online to talk that what is the response rate and how they act. As I said, the response rate of patients, the positive response rate, is pretty low. 1 in 42 show drastic change, to the extent that the family member, I have even seen it, that the family members say that, yes, Aricept was acting like a miracle for my patient, and they became very conscious and lack of confusion and all of that. Does it last long? No, like any other medication. But temporarily, it has caused again some drastic response. For about 30% of people, it has some mild improvement. But again, keep in mind that that effect can go away, fade away after a while. There is no cure for Alzheimer's disease or dementia. So there is no healing. We can treat it. By that, I mean, the best we can do is to stabilize, to avoid further decline. That's why I'm repeating those cognitive exercise TACS every 4 months. The goal is we improve them a little bit, we give them a boost, they improve a little bit, then we elapse 3 months, then they come back after 3 months, they have declined a little bit, then we give them a boost again, then again this cycle repeats. And in fact, my longitudinal data shows that indeed we are stabilizing the patients over a course of 2-3 years. I just don't have enough samples to publish it. So far, I have had only 7 patients who have been with us for 2 years. So I'm waiting to increase the sample size to publish. But I've seen it in these 7 people that at least they don't decline.
Professor Moussavi, I want to thank you so much for spending time with us and sharing your very inspiring work. I think also motivating the audience that there are so many challenges left to be solved and much to be worked on to improve Alzheimer's. So thank you very much again. And I know you can't hear it, there's virtual applause going on in the background. And this wraps up our second DL seminar. Thank you.
Thank you very much for the invitation. Thanks, folks.